This is Doug Field, CEO of the Institute of Healthcare Consumers, along with my co-host Ron Bachman, and welcome back to the final segment of Healthcare Consumers and Radio. And should be an interesting segment because this market is about to be shook up with private and public exchanges, and one of the leaders in defined contribution health benefits is Zane Benefits, and joining us today is their president, Rick Lindquist. Rick, hey, welcome.
Oh, thank you for having me.
Yeah, good to have you on here, Rick. We haven't spoken in a while, so it's nice to have you.
Yes, I've heard the advertisements for the Forum West, but I think I need to make a trip out there.
Yeah, you need to. Look forward to seeing you there. Rick, give our audience really kind of an update on Zane Benefits and your position in this space.
Sure. So the way we like to start describing ourselves is really stating the problem that we're trying to solve. So for those of you who may not be familiar with Zane Benefits on the show today, we were founded in 2006, and we were founded on the vision that the biggest problem in healthcare starts with how people get their health insurance. In Zane Benefits world, in our vision, group health insurance is broken, and we believe it's the number one problem leading to the lack of engagement, as Frank was just talking about. He said it best. You have a one-size-fit-all group health insurance plan being picked by the employer for employees with very different individual needs. When there was $0 copays or $5 copays, it wasn't a big deal. But now that costs have been shifting to employees, individual families have very different needs and desires when it comes to their health plan. So we see this problem developing in a number of different ways. First, you've got employees who, because they've never bought health insurance before, they're scared to death of it. Mm-hmm. They don't understand copays. They don't understand deductibles. They don't understand coinsurance, out-of-pocket maxes, networks. If they can't understand how health insurance is financed, how can they possibly understand how to pay for health care or the actual service they receive? Mm-hmm. So going back to Frank's segment about the employee engagement on healthcare services, it really starts with, do employees understand their health insurance, and what do they want with health insurance? So our solution is basically get out of the health insurance business. Employers, stop taking away choice from your employees, and empower your employees to get educated on this stuff. Let them go pick the right plan for them on an individualized basis. Let them pick the network. Let them pick the carrier. Let them pick the doctor. Let them pick the deductible. Let them pick the out-of-pocket max, copays. Let them pick whether they want a health savings account or a low deductible premium plan, and then give them dollars for health benefits. Instead of defining the benefit, in other words, the group health insurance plan, define the contribution that you're willing to give the employees on a pre-tax basis as the health benefits, and give them that in the form of a health care allowance. And so our solution, coming back to the question, is hey, are you tired of the group health insurance game? Are you tired of your employees being dissatisfied with benefits? Get out of the health insurance business, but don't get out of the health benefits business. Give your employees health care allowances and empower them to go get their own individual policy that best fits their needs.
Rick's Ron Bachman here. I have followed you and Zane Benefits for many years, and I've been a big fan of the work that you've done and the way you've promoted the use of HRAs, health reimbursement arrangements. In many ways, prior to the Affordable Care Act, state laws were sometimes
Mm-hmm.
limiting for how, in a given state you could use HRAs for an employer to do the defined contribution model so the employee can go out and buy individual policies. Are there any limits under the Affordable Care Act? Do they override some of those previous state laws, or how do you see the Affordable Care Act and HRAs, and really that's the core of the defined contribution model that you've been putting together? How's all that work together?
Great question. So back to your first question, which was the state law issue. We actually are of the opinion that state laws have never restricted HRAs from existing in every state. And the primary reason is that HRAs are federally regulated, and the state laws that people have referred to that have limited HRAs are actually, they regulate health insurance companies and brokers. They don't actually regulate employers or in any way prohibit an employer from setting up health reimbursement rates. So we actually have clients in all 50 states, and we have never seen that is a true restriction of an employer being able to take advantage of a defined contribution solution. Regarding the Affordable Care Act, there are some parts of the bill, because of what a health reimbursement arrangement actually is under ERISA, it is subject to many of the Affordable Care Act provisions. So you do have to take care in structuring your HRA so that it doesn't violate some of the new rules. The most important one, probably, or the one that's getting the most buzz, is the Section 2711 annual limit requirements. So you got to make sure that you qualify and structure the plan when you design it so that you're not violating those annual limit requirements.
Well, now, explain that a little bit more, because my understanding is that HRAs at the federal level, when it was established in 2003, is actually defined as a health insurance plan. So it's not exactly an account like a health savings account, although from the consumer standpoint, they look very similar. And maybe some people have a hard time differentiating between an HSA and an HRA because they're referred to as account-based plans. But legally, the HSA is just a bank account. It's dollars put into a bank, where HRAs are defined as insurance plans. So in some states, that state restriction that we were talking about before, some states would say, no, if it's an insurance plan, then it is regulated by the insurance commissioner. And if an employer is putting it up, then they're supporting it, and that makes it a group plan, makes a guaranteed issue. So there were some restrictions before that I think, maybe weren't totally enforced, but I think there were some problems there. Are those overridden by the Affordable Care Act so that they no longer apply? Because I know in the state of Georgia here, for example, we actually wrote into the law that HRAs for state law purposes were not insurance, and that opened up the door to selling HRAs here in the state of Georgia.
You got it. So you're absolutely right on HSAs. HRAs are actually, at least the way we structure them, other providers may set it up as an insured arrangement. The HRAs that we help employers establish are self-insured health plans. Mm-hmm. So they're federally regulated. They're not technically insurance, subject to state regulation. So that's how that's how the HRAs that we structure for employers escape these state insurance issues. Because if you go to any state Department of Insurance and you ask them, hey, do you regulate federally regulated ERISA self-funded medical reimbursement plans? Their answer is no. And if they say something else, call me and I'll call them.
That's exactly right.
Yep. And so, but to further answer your question, the primary issue or confusion at a state level is primarily with small groups and the early 1990s NAIC Model Act that created guaranteed issue health insurance for small employers. Mm-hmm. And the idea is, that law becomes irrelevant in 2014 because individual health insurance and small group health insurance are essentially the same thing, and are both available on a guaranteed issue basis. Okay.
So from the standpoint of the Affordable Care Act, let's take the under 50 life marketplace that's eligible for exchange, and small employers aren't required to provide any insurance under the Affordable Care Act. So it seems like the HRA approach is perfectly ideal for them to put up some money to help support the purchase of individual policies in an exchange. Is that what you're doing? Or are you doing that and something else, or even more than that?
So if you have preconceived notions of what an HRA is, you probably think of it more like an account, like you mentioned earlier. Mm-hmm. We've taken a different approach. The whole reason employers offer health benefits is for recruiting and retention. And the whole reason we're talking about it really goes back to a tax exclusion, a tax preference for health benefit dollars versus wages. And so we know that the employer, as long as there's a tax preference for health care dollars, is going to want to offer health benefits because it's better than giving someone a raise, especially with the new subsidies that a taxable wage increase actually takes away money from the employee. So we have structured a program, and it's sort of like QuickBooks Online, but for a health benefit or defined contribution program. The employer sets one of these up online, completely paperless, and really designs what they want to do. So they can give, one set of employees a certain amount, and another set of employees a different amount based on employee classes. Now, those have to be set up based on bona fide job criteria, but best example I give is a Domino's Pizza franchise that we did in Michigan early on in days, where they gave drivers $300 a month, managers $300 a month, and their wait staff $200 a month. And they basically go through a plan design wizard, sort of like you go through when you do TurboTax, and design this benefit program to meet their recruiting and retention needs. Once they set that up, the system, our software, takes care of the rest. So we automatically generate all the plan documents, SPDs, SBCs, employee notifications, and then they add employees online. And so from start to finish, it takes about 15 to 30 minutes to set one of these up completely paperless, and then employees have the benefit. So then it gets into, okay, well, how do you make this new thing sound cool to employees when they're scared to death of buying their own health insurance? So we spend a lot of time on the subject of engagement. How do we engage the employees and make them feel like this is not a reduction in benefits, but a good thing that empowers them?
Hey, Rick,
so there's an employee portal that they actually log into and can use the benefit, and they can use it in many different ways.
Hey, Rick, I really appreciate it. I hate to cut you off, but, time flies around. Time. You got about 30 seconds. Give our audience a final thought and tell them how they can find you. ZaneBenefits.com, ZANE benefits.com. We've got a lot of different resources. Check out our blog at ZaneBenefits.com/blog. Our content team does a terrific job. We've also got a resource section with over 20 ebooks on healthcare reform, defined contribution, and health insurance facts and figures. And love to hear from people. And we get a lot of opposing viewpoints because we're taking a slightly different approach, but we welcome those. And any feedback anyone has, please reach out to us directly. Thanks, Rick. I really appreciate you being here and look forward to seeing you at Forum West in December.
Yes, thank you for your time, and look forward to seeing you as well.
Okay, to our audience, thank you for joining us this week. We'll see you next week on Healthcare Consumerism Radio.
Hi, this is Brent Macy, Managing Director for the Institute for Healthcare Consumerism, and I want to invite you to join us for IHC Forum West in Las Vegas, December 5th and 6th. Come learn, connect, and share about everything surrounding healthcare consumerism.